Welcome to this video on filtering the noise in longevity supplementation. We will provide an evidence-based reconciliation of 30 compounds ranked by human biomarker engagement. We distinguish the noise, like preclinical data and uncontrolled claims, from the signal. The signal focuses on double-blind randomized controlled trials, direct biomarker engagement, and numeric endpoint extraction. We aim to move from theory to measured in humans results. Our process starts with 30 initial compounds filtered by human RCTs and meta-analyses. We extract numeric endpoints, apply a 0 to 100 rubric, and then assign a final biomarker score. Compounds lacking human data, like fisetin, are filtered out. The quantitative rubric assigns weighted scores across 5 categories. Evidence quality accounts for 30%, effect size and consistency for 25%, and biomarker relevance for 25%. Safety and dose response each account for 10%. The biomarker hierarchy ranks targets by proximity to root aging mechanisms. DNAM clocks are at the apex, followed by the NAD plus metabolome, mitochondria and oxidative stress, senescence markers, and finally, inflammatory and metabolic risk. The evidence distribution shows a stark reality. A small, high-evidence head of supplements directly engages aging biology. This is followed by a long tail of supplements with much lower scores, relying on preclinical hype or indirect endpoints. We compare industry assumptions with clinical reality. For Urolithin A, the analytical error was conflating change from baseline with between-group difference. For NMN/NR, we note strong PBMC NAD plus shifts, but no broad metabolic normalization. Looking at Urolithin A data, the illusion shows a significant change from baseline. However, the reality is that the treatment versus placebo difference was not statistically significant. Robust placebo responses frequently mimic efficacy in longevity trials. The biomarker target matrix reveals that while NAD plus precursors dominate cellular energy markers, only omega-3 demonstrates statistically detectable, direct deceleration of DNA methylation clocks in large-scale RCTs. Omega-3 ranks first with a score of 87, showing standardized effects of slowing aging by around 3 months over 3 years. Urolithin A ranks second with a score of 73, but its primary functional endpoint was not significantly superior to placebo. For NAD plus precursors, NMN ranks third with a score of 71, showing muscle insulin sensitivity and PBMC NAD plus increase. NR ranks fourth with a score of 70, showing clean, target engagement markers but relying on a small sample size. Mid-tier modulators like berberine and magnesium offer strong or modest reductions in cardiorespiratory risk factors. However, these improvements do not equate to validated aging clock reversals, despite their reliable effects on risk parameters. Low-dose lithium, despite mechanistic promise, scores low at 37 due to safety constraints. Adverse effects and the need for medical monitoring preclude its friction-free use as a broad longevity supplement. Safety is not optional in longevity framing. The biomarker function disconnect is a central principle. Engaging a plausible biological pathway, like TA65 lengthening telomeres, does not automatically translate to functional human benefit, such as improved physical mobility. Molecular success is not anti-aging proof. In strategic realities, direct biomarker engagement is measurable but modest. Pathway engagement needs to catch up with clinical translation. Supplements lacking strict, double-blind human RCTs cannot be clinically recommended until robust human data matures.